good afternoon, everybody. And this is a webinar. I'm very excited to be introducing my good friends and from Italy, Dr. Pietro and Dr. Pietro Ferraris and Dr. Giovanni Nicoli. We were just having a bit of chat before this, and it's been a while since we saw each other, and it's just great to see them as always. Before I introduce them formally, perhaps a little bit of the story behind Nazalus implants. So Pietro and Giovanni are both accomplished maxillofacial surgeons who had been doing lots of zygomatic implants before, and they still do. But in Italy, the rules are such that in private practice, you're not allowed to provide general anesthetic when doing these treatments. And so they scratched their brains and got thinking and thought, what's a better way or a different way where they could provide sort of zygomatic type treatments and treat these severely atrophic maxillae under local anesthetic. And so they got thinking about turning the zygomatic implant around 180 degrees and angling it forward into the premaxillar area rather than going backwards into the zygoma. And it was in Rome at the EAO, I believe, in 2013, that they spoke to Graham Blackbeard and started to download the ideas. And from this, of course, the concept developed, and we got cracking with working on designs. And from there, the Nazalus concept has grown. And so that's really the background. So 6 years later now, there have been many hundreds of these placed. Giovanni and Pietro have published on it and have got some lovely predictable results. So certainly this is a treatment that anybody comfortable with dealing with sinuses should be able to provide quite predictably. And of course now, particularly post-COVID, people providing accelerated treatments needing to load these things immediately, it provides another option to consider in getting good primary stability and using that premaxillary bone to be able to provide these treatments. So just a little introduction. So Dr. Pietro Ferraris, he's MD and DDS with honors, and he graduated in 1992 from the University of Pavia in Italy. He then did a 4-year postgrad maxilla and oral facial surgery specialization, also at the University of Pavia, and worked in that department until 2000. From 2002, he went into private practice in his clinic in Alessandria and Asti. And then Dr. Giovanni Nicoli, he graduated in 1997, MD, at the University of Brescia in Italy. He then did a 5-year specialization in maxillofacial surgery and worked in that department until 2008 as a MaxFac surgeon. So after 2008, he established a MaxFac unit in the Essendia Hospital. And then from 2014, he established the brand Sopridi Subtia, the clinics in Italy, which is the private practice. And so without any further ado, I hand over to Drs. Giovanni and Pietro to take us through the Nazalus concept. Thank you very much.
Thank you, Steve, for the kind introduction. And I have to thank Southern Implant UK and Ireland for the support in organizing that webinar. And we have to thank Emilio, too, from Southern Implant Italy, for the support and supporting us when we have strange ideas. So let's get started with our course. We are talking about atrophic upper jaw rehabilitation using a long transinus angulated implant and immediate loading. We have been introduced by Steve. We are friends and colleagues, so sometimes we share cases, opinion on cases. And I want to start with this phrase from Leonardo da Vinci: "Simplicity is the greatest example of refinement." When you change rules, we need to know them perfectly before changing. And because under the simplicity, sometimes always there is a good, there are good skill and knowledge of the rules and addiction. Over time, a lot of different brands and products have been placed on the market. All of them were with innovative characteristics on surface, connection. We discussed a lot about what would be the better surface, the better connection to enhance our results in implant treatment. But nowadays, I think that the real innovations are in macrogeometry. And companies have set their sights on site-specific implant made for specific technique. So we can talk about trends, only trends, and real innovation that change our way to treat the patient and to see the patient and to make diagnosis. The early experience, we start with our data. Till now, we have chosen to comprehend in our data only patients that have received fixed full arch rehabilitation. We treated in 6 years 70 patients, and we placed 110 Nazalus implant, placing on the wall 356 implant total. And surprisingly, me was surprised at first. Well, we have one lost Nazalus implant, and we have to consider that the patient who lost the implant received in 1 day a new Nazalus, and could carry a fixed partial provisional for the whole treatment. The nasal implant survival rates is quite comfortable, is 98.6%, absolutely comparable to the survival or normal implants placed in natural bone. And the follow-up of these cases is from 6 months to 6 years. We intentionally included only cases that have more than 6 months in our data. And these data were published in this paper in 219, which we put our data and the protocol of nasal that we have to discuss to correct to use the Nazalus to achieve the better results in time. And we are very proud to be the author of this chapter of the sinus bone graft book of Ole T. Jensen that we wrote together. So this is the starting of the most important, most interesting point, because in our private practice, one of the most concerning and common problem on is bone atrophy is the posterior region of maxilla. Rehabilitation could be really a challenge because sometimes we have an extension of the anterior recess of the sinus, and what possibility do we have when we have Brammer class C, D, E in our cases? When we have bone in zone 3 in the molar, this is a Bedrosian classification, we can use short and large implant diameters. And we can see now a site-specific implant, max implant, that I have been using a lot in time, because it's a specific implant designed for the upper first and second molar in the maxilla. Or we can graft. This is a available solution that is a good solution to provide a full arch fixed prosthesis, but we know that an effective treatment because we have a lot of paper stating that the technique works. But nowadays we have a paradigm shift because we are not focused on patient need, but soon the surgical technique. And what do patients really request to us? They want fast treatment, less invasiveness, on long-term reliability, affordable therapy, aesthetic results, and fixed prosthesis. We know that the use of tilted implant could be a good choice for the treatment, and the use of tilted implant can be considered an effective, comparable with the use of axial implant when we have bone in class 1-2 of Bedrosian. Mish explained how dental implants with diameter of at least 4 millimeters could be tilted to 30 degrees without causing any kind of complication under the biomechanical point of view and the biological. And here we can see a case, an old case we did in 2009, starting with angled with coaxis and max, is failing ceramic rehabilitation with we use the max angled implant coaxis 12, 24, 36 degrees, and we could give the patient a provisional screw retained in 1 day. And this is the final restoration, ceramic restoration, screw retained. We can see that bone level and soft tissue are healthy, and after 10 years, bone level and soft tissue are quite stable, because using the concept that during the surgeries, you place one clean abutment one time, you have definition of the biological width that provide long-term results. This is a more recent case we did 3 years ago with coaxis. The rehabilitation was with full zirconia crown made with passive abutment, coupled with passive abutment to obtain passivation and perfect fit. And this is the aesthetic result that's quite comfortable. So you can use tilted implant without any kind of concern about soft tissue, biomechanical and biological issues.
Thank you, Steve, for the great presentation. Zygomatic implants are another valid solution, especially for full edentulous patient with severe atrophy. Zygomatic bone is a structural bone, type D1 and D2. And patient satisfaction with zygomatic implants support is similar to the conventional implants. An important concept that we want to underline this evening is that Nazalus implant is not intended to be an alternative to zygomatic implant. It is a new weapon that you have in your pocket to try to give to your patients a good immediate rehabilitation. In fact, only 20% of patients are eligible for this technique. Nazalus implants and zygoma implants could be used in the same cases, but like in the photo, you can appreciate. In the left side, we use a zygoma technique, and in the opposite side, we use a nasal technique. And we can appreciate it, the correct distribution of the screw, and a good spread about the implant distribution and the satisfaction of patients. The CT evidence that the Nazalus implants have to pass transinus and arrive into the nasal cavity. If you don't respect these rules, you don't do a nasal technique. But zygomatic implants require a very skilled surgeon, and cost and the costs are high. And also is an operation that needs to be done under general anesthesia. So in 2013, Pietro and I started to think to use the concept of Zygoma technique measuring. Zygoma bone is a strong structural bone, but also is nasal process of maxillary bone. So we can use them to reach a good primary stability. So we decided to try the different advantages of this technique: the cortical anchorage for zygomatic implants, better volumes around the implants with bone grafting, and low morbidity and mediating loading for tilted implants. So we came up with the idea of Nazalus implants. Another concept that is very important, that if you want to do nasal technique, you need a specific device in order to perform this kind of surgery. Professor Jensen and his group work a lot on the idea to use nasal bone, but we are the first who decided to use nasal cortical bone. This is the original protocol. If we have fewer than 3 millimeters of alveolar bone, we perform bone grafting around the implants. The stability of the implants in these cases is guaranteed by the implants insert in the three cortical bone: cortical crestal bone and bicortical of the nasal process of the maxilla. But the bone around the implants give a longer life to the implants insert. If we have at least 3 millimeters of bone, we reach bicortical anchorage passing through the maxillary sinus without bone grafting. The reason is that in the time, the bone remodeling is around 1.7 millimeters. So 3 millimeters and more guaranteed a long time stability. So this protocol permit to have a primary stability obtained by bicortical anchorage and transform the class CDE in class A or B, performing immediate loading. From the point of view of the anatomic point of view, we can appreciate it with these draws that both of these techniques, Zygoma and Nazalus implants, involve bicortical bone. And these draw evidence like how the region of the prosthesis is the same, is the region of the second premolar. And another important concept is the bone contact implants. And comparing these two techniques, the bone contact is similar. In particular, in the Zygoma bone contact range is from 9.5 to 11.5 millimeters, and Nazalus bone contact range from 8.5 to 11.5 millimeters. This photo evidence where the Nazalus implants impacted the bone. That is a triangular shape of bone that have a very big cortical component, and this permits to have a good primary stability.
So the Nazalus is designed starting from the coaxial implant, the IBT 24 degrees coaxial implant, because we needed an implant that could be that need to be angled, and we examine this aspect later. And we have to use the Nazalus intrasinus, because they are talking about extreme resolved maxilla. So we are trying to engage cortical to achieve primary stability, to have enough stability to immediately load this implant to give the patient a provision, a fixed provision. So we have we needed to have a sharp apical thread, and the implant to be not more than 4 millimeters wide, because in heel side it's difficult to use more than 4 millimeters of diameter. So we measured on the stereolithographic human models distance between the second molar crestal bone and the nasal cortical, and the result went from 20 to 24. And we need to have a new device, because the traditional and standard implant coaxes were too short, and the zygoma was too long. And Sauter implant kindly provided us a new device, the Nazalus coaxis implant, 24 degrees of 20, 22, and 24 millimeters of length. This represents a great advantage for the angulated platform, especially from a prosthetic point of view, because you can use straight multi-unit abutment and place, give the patient immediate provisional fixed in a few hours. But this is, I think, the key point I must point out, because the Nazalus must be an angulated implant. It couldn't be a straight implant, because from a surgical point of view, considering the bone around the implant, the thin bone we have in the dorsal maxilla, when we place an angulated implant, and correctly speaking, subcrestal implant who have that have subcrestal correction of the prosthetic platform, the mesial and distal limit of the prosthetic platform would be at the same level of the bone. But if we tilt a straight implant at 24 degrees, the distal limit would be, when we place the implant, about 1.8 millimeter apically positioned compared to the mesial one. So we could have issues, because what happens if we have 2 or 3 millimeter and we place a angled multi-unit abutment? We could have, we couldn't reach, would not reach a good primary stability for the lack of bone during the preparation, or we could have not a good seal of the soft tissue, because when we place an angulated abutment using a straight implant, we start to define, to establish the biological width. We all know that the biological width is a nearly constant dimension that is around the implant and teeth, and is about 3 millimeter, a little bit more around implant, about 4. And during the reestablishment of biological width, we have bone loss. I'd like to use the term bone remodeling, because I don't think it's a real bone loss. But the margin, anyway, will stabilize about 1.7, 1.9 millimeter apical to the implant abutment connection. So let's see this radiograph we have taken from our archives, and let's see a radiograph of a case in which we use straight implant with multi-unit abutment. We immediately know that there is a bone remodeling that changes the shape of bone with bone remodeling, and imagine that we have only 2 or 3 millimeter bone. That could be the starting of some issues. When we take a look at a radiograph in which we have used angled implant, coaxis, placing a multi-unit abutment that is straight, we have the same bone remodeling, but the bone remodeling is directed on the plate, on the shape of the bone. So we have a different situation. And this slide summarizes the two aspects using straight implant with angled multi-unit abutment or angled implant with straight abutment. The different pattern of bone remodeling are quite clear, I think, and this could be the starting of issues for inflammatory, sinus inflammatory disease, when we have a lack of sealing from talking about soft tissues and hard tissues in that situation. Furthermore, this hexagon is not centered because on the platform there's the hexagon is shifted, and this provides a platform shifting on the distal aspect of the implant. That is another point that could provide a good seal of soft tissue working in area with extreme bone resorption. So the nasal implant must be angled. I see sometimes paper or case report that use Nazalus style straight implant, but using a multi-unit angle is not the same under the biological point of view. So there is a biological rule that transinus implant must be angulated, because if you use straight implant, we could have complication in the follow-up.
So before the operation, we have to study the eligibility of the patients. We have to study the good general health. It's very important to evaluate the amount of space and dentature state, because we have to use a very long device and very long instrument. It's important also the study by CT scan to study the form and the volume of the bone, the absence of sinus inflammatory disease, and the preliminarity prosthesis evaluation and planning. Every time that we decided to involve the sinus area, it's important to study that the sinus is free from inflammatory disease and the open ostium is good. In fact, if you have sinus affected by inflammatory disease, is a contraindication. The protocol, the surgical protocol. We wanted to underline that if you want to do nasal technique, you need a specific device and a specific instrument that are dedicated for this technique. For the initiation site preparation, we start with the first drill, passing through the crestal bone, transinus, and we arrive to the lateral bone of the sinus. This is the crucial part of the operation, because you have to work with the angulation drill in a very cortical bone. In fact, now we decided to use a tip drill to do an invitation, and after with this drill, we do a complete preparation of the site, and we arrive into the nasal cavity. In the first time, we dissect the nasal mucosa, but now we understand that is not necessary for two reasons. The first reason is that the patient can tell you when you have arrived into the nasal cavity, And if you go slowly with the drill, you can appreciate it when you arrive, when you pass completely through the nasal process of the maxilla. It's not a problem if you arrive 1 or 2 millimeters into the sinus, because you arrive in a tilted position, so you can't do any damages on the nasal mucosa. If we have less than 3 millimeters, you perform a lateral windows of the sinus. We suggest for the first time on learning curve to do this in every time to show what are you doing clearly. After this, with a dedicated probe, you can measure the length of the site preparation. Like in the Zygomatic technique, you choose the length of the implants in this moment, and you choose the final drill that you have in 3 measures, 20, 22, and 24 millimeters. And after you put the implants inside. These images underline that the Nazalus have to pass through the sinus and involve completely the nasal process of the maxillary and enter into the nasal cavity. If you have done antral windows, you put bone grafting. And this slide summarizes the whole technique. If you don't follow this protocol, you are not doing a nasal technique.
And now let's point out, let's answer to a question that very often the colleagues that participate our courses in Italy give to us, that what does what does interliteral liters tell about implant exposition inside maxillary sinus? Because some colleagues are concerned putting an implant into the sinus without grafting. But nothing happens at all, because implant exposition is not in itself a cause of any kind of problems. Only the penetration of foreign bodies, graft or bacteria could cause inflammatory disease of the sinus. So we can pass through like Zygomatic do. And this is the next key point we would like to discuss with the colleagues, because the patient selection is very important to have long-term results. We need at least 13 millimeters of height at the canine eminence to have a good position of the Nazalus, because if you tilt more than 24, 30 degrees the Nazalus, we would have an excessive pro-inclination. I have read some paper in which colleagues wanted to place Nazalus at 55, 60 degrees of inclination to achieve the emergency of the prosthetic platform of Nazalus at first molar. But I think this is not necessary, because biomechanical issues we could have biomechanical issues in this time. And we need the anterior wall of the sinus to be very concave or straight, because we have to approach to that wall with the drills, and we know that it's very difficult to penetrate cortical acting with the drill not normally to the surface, and find the path of the first drill using the other drills after till they're placing the implant. So we have to screw the implant, finding the hole we did with the final drill, and it's easier to engage that the preparation is the anterior wall is very straight of concave. And we must remember that Nazalus must be transinus, because it's an implant made for the treatment of severe resorptive maxilla. Sometimes I see Nazalus used in native bone. If you have a lot of bone, you are only using a long implant. You are not doing a Nazalus according to the protocol. Sometimes we have seen works made with no sense, not following the original protocol. And the Nazalus have to engage 3 corticals. One cortical is on the floor of the sinus, and the other 2 corticals are on the anterior wall of the sinus and the lateral nasal wall to have a high primary stability. And this is the moment you are looking for the blood. Well, let's see 2 more cases. This one was a case of 60 years old women with a failure denture. We placed 2 Nazalus on the left and the right side. We have to graft the sinus both sides, and we were lucky to find some bone to place a max on this aspect too. And this is the rehabilitation, an acrylic denture rehabilitation with good aesthetic results and good bone level and stable soft tissues.
And this is the last case. It's a very old case. We performed this case in 214. With this RX, you can appreciate it, the correct indication to do a nasal technique. Angulation between the floor of the sinus and the medial wall is about 19 or more than 19 degrees. So we can do a planing with the CT, and you can see that is a correct case to do a Nazalus implant. In this imaging, in these photos, you can appreciate it that sometimes it's necessary to across the tip of the implants, because the residual bone is very little, and in this case, we have a crestal bone that is in the both sides is less than 3 millimeters. So we did a lateral windows and bone grafting in the both sides. And this rakes control. You can appreciate that the bone is completely around, the implant is completely around the bone, but the stability is guaranteed from the 3 cortical anchorage of the implants. In the other side of the slide, you can appreciate the correct distribution of the implant. This is the final solution. You can see that the implants go into the cavity, nasal cavity. The patient was happy about this type of treatment. With this little webinar, we want to underline and to do a clarification about the nasal technique and nasal indication. We enjoy to share our experience, but this
friends and colleagues.
But we want to underline that if you want to do nasal protocol, you have to respect these rules. is necessary to learn more about the bone and the particular aspects of this technique. To have a course that during 1 day and a half, and we do every year when COVID permits. Thank you for your kind attention. And now, Steve, we are ready
for questions.
Okay, thank you very much, gentlemen. That was very interesting. Guy McClellan asked a question. He said, how have you decided on 3 millimeters?
Because the 3 millimeters rules come from the concept of the biological width, because we know that placing an implant, connecting it to an abutment, define the biological width definition, and we prefer to have bone around the implant, because you know the hard tissues, bone, protect soft tissues and vice versa. So soft tissues is a covering from hard tissues. When you have fewer than 3 millimeter, you have to graft to protect the soft tissues.
And to avoid the future fistula, but the graft is important, that not guarantee the stability of the implants, but is only to give a long life of the implants itself.
Then Dr. Hamid said, what graft material do you prefer to use for this implant?
It is the same. In reality, this graph is very simple, because you have 2 bone walls, and so the dissection is of the mucosa is without tension. So in reality, you can put nothing if you want. It's not a problem. You can use everything.
But anyway, it's a xenograft.
Yes, in general, we use xenograph or we PRF combination.
We graft the bone. We keep the bone from the patient, mix to a xenograft, and use a PRF technique together.
Yes, but you can use everything you are usually to use.
Okay, thank you. Then Matthew Bird asks, what is the difference between transinus as described by Testori Marlowe and the Nazalus?
No, I think the difference is that the Nazalus implant is a device created for the transinus techniques specifically, definitely at the end, because you have to use a specific device to avoid complication. So the Nazalus is a transinus implant, but specifically designed for that technique to avoid complication.
Right, thank you. Any further questions? Okay, thank you so much. Oh, hang on. Matthew, would you please ask? Okay, I'm just waiting for a question to come up. Okay, Michael Sparks asks, so then there's no problem placing an implant into the sinus?
Pietro explained well during the presentation.
No. Yes, because there are a lot of papers, there's a lot of literature about that. Placing an implant through the sinus with no graft is not itself a cause of complication. Complication starts when you place a graft that is not well placed, or penetrate bacteria for a lack of seal around the implant. For example, when you don't graft it, you have a little bone and you have a lack of seal in the definition of the biological width. This is the key point. The complication of the Nazalis could be similar to those coming from the use of Zygoma intrasinus with the old technique approach intrasinus.
In fact, this the idea born the use the whole concept to the Zygomatic technique that pass to the sinus without any bone grafting.
Okay. Then again, another one is, what is the minimum thickness for the crest and the minimum buccopalatal bone thickness for the Nazalus?
We experienced that we need at least 6 millimeter of width, because with narrower crest it could be difficult to place a 4 millimeter diameter implant.
Yes, the problem can be born when you have a very thinness bone that you have to use for the final preparation only of the crestal level to a drill of 4 millimeters, because in these cases the crestal bone lose the elasticity of the bone, so you can broken the bone with the implants if you have not do a correct preparation. In this case, you finish with the grafting around the implants.
Okay. Then another question, do you change your technique if you perforate the sinus membrane during window or osteotomy perforation?
But it's very difficult because also if you have some sinus perforation is a grafting that do a collapse of the membrane, because your dissection are from a triangular to a line dissection, so the membrane is not in tension. So also if you perforing, when you do a complete dissection, you reduce the perforation, you put a membrane, is not a problem. It's a very advantage sinus graft for two reasons. One is this of the tension of the membrane, and the second is that you have the blood from two walls, the floor and the medial part of the wall of the crestal wall of the sinus.
Is a more simple way to do a sinus lift, because you are helped by the two walls
Yes.
we are working on.
You avoid the tension of the traditional sinus, for example, in the region of the first molar, when you have to do a creation and tension of the membrane, so perforation is more difficult to management. But in this case, you reduce the tension of the membrane, and so the problem is very, very slow.
Thank you. Okay, again from Dr. Guy McClellan, do you assess soft tissue type, and do you treat any differently depending on this? Do you carry out soft tissue grafts, and if so, what is your technique?
Well, we try to help ourselves with the soft tissue. When we don't have enough keratinized mucosa, sometimes we need to graft to protect the sealing of the mucosa around the multi-unit abutment.
Yes,
yeah.
But the concept important is that if you put bone grafting, you avoid the problem of fistula. If you have more than 3 millimeters, you have a stabilization of the mucosa. In general, only the graft only if you lose the keratinized mucosa.
Anyway, as a general rule, I think that grafting soft tissue always could help for long-term success, I think.
Thank you. Right, from Dr. Ludovic Denglos, do you perforate the nasal wall with a pilot drill like for the Zygomatic protocol?
You perforate the nasal wall with the first drill.
No, yeah, no, with the first drill is not a problem, because the tip drill we use only to do an invitation of the crestal, the third part of the crestal bone. And after you use a preparation drill that have not a very tip, and you arrive tilted in the tilted position in a mucosa that is not very vascularization. a big vascularization. So it's not a problem if you enter 1-2 millimeter into the nasal cavity, because you can create any damages. You don't arrive in a parallel way, but you arrive in a tilted position.
Okay, thank you. From Dr. Bird again, when would you choose a zygomatic implant over a Nazalus implant?
The cutoff of the patient selection criteria, because if we have the condition in which the patient has 13 millimeter of highness in vital in canine eminence, and have the selection criteria to place Nazalus, we perform a much easier surgery than placing a zygoma. So the cutoff is the criteria of selection of the patient of the Nazalus technique.
Also, another concept that is very important, that when you finish and you show, for example, the last LX that we show, you can see that your operation is like a classic colon 4. So all the implants are in the maxillary. So when we can, we prefer to choose nasal, because it's more easier. And
it's a surgery with a low impact and low cost.
Yes, but it's a completely another indication about the zygoma. It's not an alternative, it's a new weapon in your pocket, like maxi, like angulated implant.
Okay. Right. Well, thank you very much to both of you for spending this time with us. Thank you to everyone who attended the webinar with us this afternoon, and have a great day.
Thank you, Lisa.
Thank you. Bye-bye.
Bye.
Thank you.
Bye.
Bye.